Dr. John Bennett, broadcasting from a cyber cafe in Kathmandu, Nepal. Tonight we have another weekly in the series of ACNS Hangouts. Tonight we have the pleasure of having Slaven Gotkovic. I call him the wonderkind of neurosurgical students from Croatia. He's a dedicated student that loves anything neurosurgical, including the dissection of rats' brains. Um, and we are also joined by a few panelists. Let me introduce them before we turn it over to Slaven. Hello, Diana.
Hi, my name is Diana Medina. I recently graduated with a master's in biomedical sciences, and I'm currently applying to medical school at the moment.
Very good, Diana, and she's networking in the neurosurgical community. Okay, Pradeep, welcome. Could you please introduce yourself?
Hey, hi, I'm software developer, as John told you. So I'm working in a software companies from last 5 to 7 years, and right now I have some thinking about my startup. So I'm here just to give the new interface to the neurologist.tv. So welcome all, and thanks.
Very good, and we hope we might be working with Pradeep to produce an interface which will be very friendly for the viewer. Okay, Slaven, welcome, and it's all yours.
Hello, welcome, esteemed panelists, and Dr. Bennett, thank you again for having me here on this amazing platform, which really is a kind of a weekly habit for us here. Today I have the privilege to present about the retrosigmoid approach, which is really one of the most, for me, one of the most spectacular approaches to the posterior fossa of the skull. And in order to do this, I will try to combine few materials to provide you really a sense of how this approach is done from all sides, let's say, and also to include some surgery. I promise it's not going to be long, and I hope you're going to enjoy it. So for the beginning, let me just say that the retrosigmoid approach, as we discussed previously in these Roton Hangouts, is part of the posterior approaches to the skull. That means, let me try to show you this better with screen share. I have a presentation here prepared for you. I don't know if you can see this image here.
Yes, excellent.
Okay, great. So what this picture wants to show is the posterior aspect.
At the bottom of the screen, could you get rid of that Google Hangouts and sharing
of
your
course,
screen? Yeah, perfect. Thank you.
Thank you. Okay, thank you, Dr. Bennett. So what you can see here is the posterior aspect of the skull, and it is intended to show you the region we are talking about today. So this is the occipital part of the skull. It is outlined by the lambdoid suture, as most of you know, and sagittal suture is seen up here, verging toward the vertex of the skull. And for now, we are just going to position our retrosigmoid approach according to the skull. We will need few landmarks for this. And first of them is this inferior nuchal line, as it's called. It's a transverse crest on the back of the occipital bone, and it basically goes from inion to inion. These are the signs. These are the landmarks on the skull, which are used by anthropologists as well as neurosurgeons and other neuroscientists. So basically, this is one of the most important landmarks. And just to show you, the retrosigmoid approach we will discuss today is positioned just around here. Okay, on either side. It can be smaller or greater, which is greatly determined by the extent of pathology. But this is kind of the image that you have to have in your mind as we proceed. So the most important first fact is that this is the posterior approach, and it is done through a retromastoid craniotomy. So this is the mastoid process behind your ear, behind and a bit lower from your ear. And this is one of the retromastoid craniotomies. So retrosigmoid approach is done after a retromastoid craniotomy, which is positioned here or here, respectively, on either lateral side. Let's go a bit behind. And as you recall from the last presentation I gave, this is the skull base viewed from the inside. You can appreciate the three cranial fossae as I discussed. And as we proceed, I think this nicely shows you where this approach is really held. So if this is the occipital bone, it's positioned and it goes through the very lateral side of the occipital bone. That means the side which is really far from the midline. Okay, the most lateral approach and a bit lower approach than this, I mean caudally positioned, is the far lateral and transcondylar approach. But today we are going to focus on the retrosigmoid approach, which can be seen here outlined by this arrow. Okay, this image you already saw. And before I go any further, I would like to show you one other aspect of the literature I'm going to use today. This is the book by Professor Roton, which is really one of the top resources throughout the Roton course. And here you can appreciate basically the positioning of the patient. I hope you can see this image. And it's basically how the patient is positioned. So the surgeon is seated usually at the top of the table here. The Mayfield skull clamp is positioned so that it keeps the head in place. And the position of the patient, which as some neurosurgeons jokingly say is always natural in neurosurgery, is basically a three-quarter prone position. So the face is three-quarterly face down to the bed. This is also called the lateral decubitus position. And here, as I said, you can see nicely drawn the position of this retrosigmoid and retromastoid craniotomy. Okay, so it is positioned right here. This is also the usual extent of craniotomy which is performed. Very important vascular landmarks of this fossae, which really, after which this approach is called, is the sigmoid sinus and transverse sinus. So you will notice that this approach is called the retrosigmoid approach, which means that it's positioned behind the sigmoid sinus, which is really how this images can be seen sharply. And also when you finally do the craniotomy, that means when you do the skin incision, which can be curvilinear or dandy incision, it can be then you can cut out the bone with the craniotomy, open the dura, and you get this extent. And if you followed closely my presentation of the last time, I mentioned that this area inside the skull is called the CP angle or cerebellopontine angle. This is actually the area that is accessed through this approach. So the purpose of performing a retrosigmoid approach is, in most instances, to approach the CP angle from behind. And this is one of the approaches which is most widely used to perform exactly approach to this region. Also outlined here are the important cranial nerves. This cartoon helps us to see this anatomy schematized a bit. We will later review the cadaveric pictures of this approach. So this is the seventh nerve, eighth, fifth nerve, and fourth nerve. And this is actually the extent of anatomical places which you can manipulate through this approach. So it is very important that it is limited. It can be extended with the use of rongeur or T-Rex, as it is called. It's an instrument which is used to cut out pieces of the bone and remove them. After you have done the initial craniotomy, this craniotomy initially may prove to be too small and needs to be extended in case that the pathology exceeds the operative corridor we imagined. Okay, so these are just a few images that we have to have in mind before we start. And while we are here, let me just show you the first of the anatomical images. This is the Professor Otton's book in a PDF. This is a legally bought copy, and I really suggest for everyone who is amazed by this to purchase this hardcover or this and enjoy this anatomy. Let me show you this. And all this crazy mess of anatomical structures is what is approached by this approach. And this is the CP angle from behind. I think I confused you enough by this time, and now I'll go back to the presentation to show you this in a little bit more organized manner. Okay, so as I mentioned the last time, if you remove the complete skull bone of the occipital region and even further of the neck and do this anatomical dissection, you will basically see this extent of approach inside of the skull. And if you remove the cerebellum, which is positioned behind the brainstem here, this is the brainstem, you will see the floor of the rhomboid fossa. And rhomboid fossa is the fourth ventricle, or the lowermost fossa inside of the brain, which is really a space, an anatomical space that connects the cerebrospinal fluid of the spinal canal, which is positioned inside the spinal cord here and inside of the brain, through the aqueductus of Sylvius here, and through the foramina of Luschke, positioned here, and foramen of Magendai. But for now, this picture is not really the seat of our interest. It just intends to show you the region we are discussing today in a bit more anatomical fashion. This is just the dura on which the cerebellar surfaces, namely the suboccipital surface of the cerebellum, lies. And this is the petrosal, the posterior aspect of the petrosal part of the pyramid of the temporal bone. This is a very complicated anatomical name, but let's just say that this is the temporal bone, and it has these pyramids which converge to the midline of the skull base. And these pyramids are actually have four faces. And if you observe, there is a posterior face of the pyramid which looks inside of this posterior fossa. So this is a 3D fossa, and in this fossa, the petrosal surface, or the anterior surface of the cerebellum, goes right here. It lies on this posterior aspect, and that's what I'm trying to discuss. So in order to approach our most valuable anatomical landmarks for this operation, and those are the 7th and 8th nerve, as well as the 5th nerve, and other anatomical places, we need to retract the cerebellum, which is usually positioned here or here, and then provide the exposure. Let me go a bit further. These are the arteries, as we discussed. So the vertebral artery is connecting the midline to form a basilar artery, and there are three arteries along with the basilar artery that supply the brainstem and cerebellum. And these are the basilar artery, pica, or posterior inferior cerebellar artery, ICA, or anterior inferior cerebellar artery, and SCA, or superior cerebellar artery. Here upwards is the PCA, that is the posterior cerebral artery, and it's part of the circle of Willis, which means that it supplies the cerebrum, or the large brain, as opposed to the small brain, which is positioned here. Okay, and now one of the most important images for our today discussion is exactly this. So as I mentioned, to position the retrosigmoid craniotomy, and this is the sigmoid sinus, as you can see here, because it curves like an S. That's why it's called the sigmoid sinus. To position it, we need to find the retrosigmoid region of the skull. Of course, in a patient, when you position him for surgery, you don't exactly have the X-ray vision, so you have to use some anatomical landmarks on the skin to be able to see this. And what's important here is the root of zygoma, which is here. Here goes the arcus of the zygomatic bone or arch, and here is the inion. So you basically just connect the line which connects the inion and the root of the zygoma into a transverse line or horizontal, and you have first of the two lines which really show you the where to position your skin incision and craniotomy. And basically this is the line which, if you see, if you look, if you imagine a line here, it really outlines the lower margin of the transverse sinus, and here it intersects with the sigmoid sinus. Okay, then you find the tip of the mastoid, which is here. It can be palpated under the skin, and follow the mastoid groove. And at the end of this mastoid groove, on the posterior aspect of the mastoid, which can be really palpated as well, you draw a perpendicular line here, and the place where it intersects with this horizontal line is really the place where the junction of the transverse and sigmoid sinus is positioned. So just to go again, the most important vessel or anatomical structure that you must not injure in this region are the sinuses, apart from others. So basically, and also to put in an approach which is called the retrosigmoid approach, you need to find under the skin where the sigmoid sinus, transverse sinus, and bones are located. So in order to do this, you draw a line which connects the arch of the zygoma and the inion, and then find the posterior line of the mastoid, pull a perpendicular line, and here you can see the junction of this. Your retrosigmoid craniotomy is really positioned right here. That is the retromastoid craniotomy, but retrosigmoid approach. So right here in the junction of the transverse and sigmoid sinus. It should go just approach these sinuses in order for them to be visible, but not go over them. Because if you go over them, then you will not be able to really operate in this field through a small opening. Neurosurgery is a minimal invasive discipline, so it's very important to place your approach accordingly in your craniotomy in order to dissect as little of anatomical structures as possible and to deviate the natural state of things as less as possible, as little as possible. Okay. And now just to repeat what we discussed the last time, the cerebrum or the small brain has three surfaces. This is the upper surface or the tentorial surface. It is called after the dural lining which covers the upper surface of the cerebellum, and it's called a tentorium cerebelli. It's named after a tent. So tentorium is like a little tent of the cerebellum. Okay, and here is the sagittal sinus in the midline, at the posterior part of the cerebellum. The structure in the middle of the cerebellum is called the vermis, and the lateral structures are called the hemispheres of the cerebellum. And finally, we can see ICA here branching. I discussed this the last time. And here, as we go curve around to the front, around the brainstem, we can see the CP angle. So CP angle is basically this area here between the cerebellar surface and the brainstem. So if you look at these structures, they really form an angle, which is called the CP angle. And this is exactly the anatomical position we are trying to reach through the retrosigmoid approach. What you can also see in this image is that in order to approach these regions, you need to retract the hemisphere of the cerebellum. So like this to the midline, in order to come to this CP angle. So basically, you really retract, whether with your instruments or with the retractor, the cerebellar hemisphere through the craniotomy you made, and you approach the CP angle, and then you can do the surgery in these regions. Also, here is one of the most commonly I wouldn't say most commonly, but one of the common procedures which are done through this approach, and this is the operation for trigeminal neuralgia. As I mentioned the last time, the SCA, which is a superior cerebellar artery, curves around the brainstem. Again, here through the mesencephalic fissure, and then branches on the tentorial surface of the cerebellum. So it goes like this. And on its way, it reaches this trigeminal nerve, which is positioned right here. As we get older, these arches of these loops of the SCA get lower and lower. And sometimes in some cases, they can reach the trigeminal nerve and with their pulsations cause pain, which really radiates to the face and is one of the worst pains a person can experience. It's numbered 10 out of 10 on a scale of 10 of pain. So it's a worse. It's a very bad pain the patient can experience, and it really is one of the reasons why these persons commit suicide. It's really serious and very disabling for them. So in this surgery, the region of the cerebellopontine angle, which is right here, is approached through the retrosigmoid craniotomy, retromastoid craniotomy, and retrosigmoid approach. And then a piece of Teflon is put between the trigeminal nerve and the loop of the SCA. And this is the decompression procedure, which really allows the pain to be relieved. It was first done and presented by Peter Giannetta in the first half of the 20th century. Okay, so as you go further, this is the upper aspect of the CP angle or view from above. And finally, the CP angle from the anterior aspect. This is again the cerebellar surface, the brainstem, and here is exactly the CP angle. As you can see, most cranial nerves are positioned in the CP angle. So they are the structures which are most commonly operated through this retrosigmoid approach. So the hemisphere again is retracted, the cranial nerves can be approached, and various procedures can be done. This is just the foramen of Luschka, which I discussed last time. What's amazing with it is that it's positioned on the anterior aspect, and it really connects the posterior part or the main space of the fourth ventricle with the anterior CP angle, which is positioned here. And finally, again, the SCA or ICA, this is actually ICA here. The SCA is up here, and this is the trigeminal nerve here. Trunks can obstruct the nerves. They can come in contact with them and impinge the nerve, which causes pain or other diseases. Actually, in this region, hemifacial spasm can occur. This is shown in further images, and I will mention this as we go on. And again, the gross total view of this anatomical region. This is a very interesting place to discuss because these are the 7th and 8th nerve in the CP angle, and basically one of the pathologies which are very important in this region are acoustic neuromas. So basically schwannomas or acoustic neuromas of this region are the tumors which occur in the lining of the 8th nerve. So this is the 7th and 8th nerve. And then they can extend to such an extent that they really deviate the anatomical structures. As you can see, this is really closely packed here. And if you have a large bulge of tissue here, which grew from the nerve, it really distorts the anatomical structures here. So one of the main goals of surgery in this area is to remove this tumor without disrupting the nerves, if this is possible, and to achieve the anatomical relief of this region. This also increases the CSF pressure and other diseases as well. So now this is exactly the view that you have through the operating microscope of the CP angle from the retrosigmoid approach. So if we approach from the behind and the retractor is placed on the cerebellum, we see here the 7th and 8th nerve coming inside the porous of the internal acoustic meatus, and we see the vascular structures. As we further go inside of this region, we see the 7th and 8th nerve enter this porous, and as they branch, sometimes they're followed by the ICA. And this can really cause many problems, because the ICA can also pulsate on the surface of the 7th nerve, and with this it can cause hemifacial spasm, which is a grotesque disease which really is also very disabling for the person, and it can also be tackled with the retrosigmoid approach, and this is why we discuss it here. Other pathologies which are common in this region, apart from schwannomas, which arrive in the 8th nerve, are the meningiomas, 15%, and other tumors which are really, really rare. And finally, this is just to show you what are the lateral anatomical structures here, the Bill's bar and the branches of the 7th and 8th nerve, and the look at the posterior surface of the petrous bone here, okay, to which the anterior or petrosal surface of the cerebellum is aligned to. Is everything okay? I can hear some noise.
Yes, it's okay. I'll turn it off. I'm sorry.
Okay. Perfect. No, perfect. Okay. I'm just checking. Okay. And finally, just not to really strangle you further with these boring, somewhat boring facts, we will just skip this and then go on to the operative video. So this was the Thiele-Willer approach we discussed the last time. And just another thing I want to show you and mention is here in the Rotov's book. I didn't want to cut out this book in order not to violate the owner's rights of the work. So this is all part of this amazing book, and this also allows you to enjoy a bit how this book is organized. I mean, so many images, photographs. It's really amazing. But there is a specific image I want to show you just now, and it's basically the image which really is powerful. I think when we discuss the retrosigmoid approach, it's not this image, but it is connected with what I want to show you. As you see, the retractor here is placed in a specific position on the surface of the cerebellum. So it retracts the surface of the cerebellum to the midline and a bit upwards. Okay, and this really allows the surgeon to approach the trigeminal nerve. So I'm sorry, this is actually reversed, because the surgeon is sitting, as you can see here, on the top of the head. So basically what is upwards here is downwards on the skull. Okay, so you're looking at the patient's skull from here, and if you pull the cerebellum in this direction here, you will see the upper part of this CP angle. If you pull it medially, just horizontal medially, you will see the lateral aspect, and if you pull it upwards, according to the anatomy of the scalp, then you will see the lower aspect of the CP angle. I hope this makes sense. This is the point I wanted to make. And here you can see this surface of the cerebellum pulled downwards to the lower part of the occiput, and also medially. And that allows you to approach the trigeminal. So the point I want to make is that with specific retraction of the cerebellar surface, you can approach different regions and different anatomical structures in this region. So this is a very, very interesting and powerful tool. Finally, the image that I mentioned, it shows you also how the craniotomy varies, the retromastoid craniotomy, as according to the procedure which is planned, and it shows you how this surface of the cerebellum can be retracted in order to operate in this region. And this is the medially horizontally retracted cerebellar hemisphere, which allows you the somewhat the largest extent of exposure. This is the downward retracted cerebellar surface, which allows you access to the upper structures, namely the trigeminal nerve. And this is the upward retracted surface, which allows you the approach to lower region of the CP angle. And there are many informations here in this book, and I will not really go through this any further. And now I hope that you overall and basic understanding of this retrosigmoid approach, and we will test this also, and you will be able to assess how much do you understand this through the video I found here, which I think illustrates nicely how this approach is done. Also, one more thing is that there are many videos on YouTube which you can use, but I personally chose a video from the ANS. It's all part of their channel, WANS Neurosurgery, and it's named Retrosigmoid Approach for Resection of Cerebellopontine Angle Meningioma. And now, as the video goes, here are the authors. Just a moment. Just to show them. So this is done by Lee Tan, Gerard Ahuja, and Woftakar, which are, and it's a really, I think, nice video. It's short, and it shows you something. So this is the cerebellopontine angle anatomy. Again, we discussed this in detail. And also, as I mentioned, large amount of tumors is positioned in the CP angle, and most common are schwannomas and meningiomas. As we go on, let's proceed to the positioning. So this was the MRI right here of the patient. You can see that the patient has a meningioma or a tumor in this region of the left CP angle, which is also including the left trigeminal nerve here. And the approach that will be done is the left retromastoid craniotomy. And this region of the left CP angle will be approached to remove the tumor. This is how the patient is positioned. So this is the lateral decubitus position with the Mayfield skull clamp in place. And this is the curvilinear incision which is placed here. According to the landmarks, there are many variations to this incision that can be done, but this is, let's say, one of the more conventional ways to do the incision. Also, I would recommend, while we are here, the amazing videos on all the neurosurgical approaches by Professor Cohen Gadol, which are part of the Neurosurgical Operative Atlas. And it's really amazing to, if you want to go further into details of this approach, you can watch those videos. I think they have really great materials and are great to go into further discussion about this. And now let's approach with let's proceed with this approach. So around here starts the operative video. Okay, let's just wait. One of the points that was made by Cohen Gadol in his videos is that his team and himself usually put a lumbar drainage in order to drain out the CSF. As it usually is the case with tumors in intracranial tumors, they really raise the ICP, or intracranial pressure. And if you drain some of the cerebrospinal fluid, it can help relieve this pressure, because one of the worst complications in any kind of intracranial surgery is increased ICP, which can really cause devastating effects, such as protruding of the brain through the opening of the dura and other really catastrophic events. So now here is how the incision is being done by a scalpel. These are the outlines which are mentioned. So the horizontal line, and basically here the this vertical line, which shows the junction of the transverse and sigmoid sinus here. This is a rather small skin incision. And now when the bone is exposed, cautery is being done, and also the anatomical structures attached to the bone are detached. Burr hole is placed with a drill. Also, the saline is applied to clean the area, and suction is used to suction away the debris in the area. Then a craniotomy is applied in order to make the further dissection of the area. So to perform a craniotomy, usually it's done. What is done here is the osteoplastic craniotomy. This means that the bone flap is intended to be replaced after the surgery, but right now sometimes it's rongeured out, and this cannot be done. So in some cases where the craniotomy needs to be like this, this is the rongeur. In place where it needs to be extended, then it's really needed to. It needs to. You need to use some other methods of closure, such as metaacrylate. So the blade is again used to open the dura and to relieve the intracranial pressure. This is the case without the lumbar drainage. And then the scissors are used to sharply dissect and open the dura. This is done under the microscope. CSF is now released, and suction is also used in order to remove this furtherly. So this is the view under the microscope. As you can see, it is magnified. And here is the posterior surface of the cerebellum, or the suboccipital surface. More precisely, the hemisphere. This is the left hemisphere. Okay. And then the dura is retracted with retraction sutures. A piece of cotton is placed on the cerebellum in order to retract it, as I mentioned. And as you can see, it is retracted now downwards in order to provide exposure of the so this is basically, I'm sorry, this is upwards in order to provide the exposure of the 9th, 10th, and 11th nerve, and also the pica. This can be modified during the surgery. Then flocculus and cranial nerve 7 and 8 are visualized, which are in the middle part. And finally, as the dissection proceeds, the trigeminal nerve will also come in view. As you can see, it's a very tight anatomical area, and much care must be applied not to injure any of the nerves here or vessels. So the tumor is visualized. This is the tumor tissue. So you basically area until you visualize the mass that is not supposed to be here, and that's the tumor mass. It really is all around the nerves, as you can see, and it's really ugly looking in this region. So the tumor is cauterized its surface in order to be able to be removed, because tumors are usually kind of a gel-like appearance, and this allows them to be coagulated as well as to be more easily handled by the surgeon. When it comes to meningiomas, usually the 4Ds, the 4D tactics is used. It means the this is the tactic which applies cauterization and then handling of the tumor, and enables the surgeon to remove it without any further deficits. Dissecting tumor away. Okay, so now trigeminal nerve comes in view and tumor is dissected away from it. Again, what is used here is just a suction and a hook, and finally the bipolar and suction, which also allows you to coagulate and to handle the structures. This is sharp dissection here to resect some of the tumor adhesions. And finally, the resection of the tumor is proceeded until the full or gross total resection is performed of the tumor. This is after surgery. As you can see, it's really here performed. We cannot see observe any tumor tissue in the area. Finally, the closure is done with 4-0 sutures in this case, which I think is a good tactic. And these sutures adjust dural edges one to another. And finally, the bone flap is replaced with various plates here, which are metal plates and which hold this bone flap in position. And finally, the skin is stapled back or sutured back in a standard fashion using the sharp sutures. And finally, this is the post-op result. As we can see from the prior surgery, there is no visible remains of tumors here in this area, and gross total resection is observed. So again, I use the WNS video, which I think is really good to help in this in these discussions we have. And now I will go back to the presentation. Let me just get off the screen share. Okay, everyone. So thank you for listening to this. I am now open for questions. I would like you to, I really hope that you really could understand what I talked about and all these anatomical descriptions. I tried to be as detailed as needed for you to get some overview and overlook of this approach, and also to be able to think about it and to understand how it's done, where it is positioned, and what is the purpose of performing this approach. So now I would like to please give any comments or questions that you have, and thank you again for your kind attendance.
Okay, Slaven, excellent. You have a great future. That's why I call you the Wonderkind. I'm sure that Rakesh will agree with me. It's so important for a neurosurgeon to know his neuroanatomy, and I think you're doing the right thing at spending a lot of time with Rotan and the excellent videos by the ACNS, because it'll stand you in good stead later on when you're a neurosurgeon, where you continue to study neurosurgery. As Rakesh, I'm sure, will tell you, it's a lifelong study in neurosurgery, but it's such a basic tool of neurosurgery just to know it cold, because you're dealing with such vital structures. As you pointed out, those nerves, 9, 10, and 11, you're very close to them, and you've got to be very careful, and you have to know exactly where they are at all times. So just like I think Pradeep will agree with coding and computer programming, knowing HTML is basic to programming, and neuroanatomy is basic to neurosurgery. So any comments, Rakesh? Any comments, Rakesh?
Yeah. Thank you, Dr. John. And very nice presentation, Slaven. I just joined in between, and I think I saw the video full, and the ANS video was very good, and it's the most common approach and the simple tumor you demonstrated each and every step. and this video will be actually in YouTube. And for everyone who is like wants to know about retrosigmoid approach, and the way you have uh, shown that video is very simple, and it's very good for the initial learner. So a very good presentation, and hope every Sunday there will be some this thing, and even if it is brief, it's okay. But we have to have every Sunday we have to have something like this. And together, what you have introduced today is a video associated with that. That the most common approach, and ANS, the most standard ANS video. So it's better that you attach a video with your presentation. After your Roton presentation, you attach a video and explain the way you did today. A very good presentation. I hope the same thing continues every week.
Thank you very much, Rakesh. It's really nice to see you here on the
Thank you.
panel. I'm so thankful for you because I mean I know that you're working and you are
Yeah, I
dealing
came
with
from the
real.
hospital now.
Yeah, so it's really a pleasure to have you here and
Well, you know,
something
Slaven,
like
I
this.
have to agree with Rakesh. Having a guided tour of that video, you know, watching the video is really good, but having someone like you who knows the way around guiding you through that video, that makes it even more powerful, I think,
Yes.
as an educational tool. Wouldn't you say, Rakesh?
Yes, yes. So even if in your Roton courses where you do in Croatia, so it's better
Mhm,
after your, because it becomes monotonous. After your Roton pictures,
mhm.
you add a video, a simple video like this, not a complicated video, a simple video where the tumor is not extending much. It is in a simple place, and you show the nerves. So that will be better. That will be very good for immediately after your Roton presentation.
Thank you very much,
You
Rakesh.
know,
Yeah,
I think that Dr. Ho said the same thing, Slaven. Same
Mhm.
thing. He likes the way you do these neuroanatomy with combinations of video and pictures.
thank you. Yeah, because I think it's really important to use all the available resources in order to capture the context or the idea which is presented. Because, you know, usually what I mind in some presentations that I observe is that they approach it from a specific angle. I mean, either they are full of text or something and they do not give you an overall perspective, and this is really what I try to do, and I'm really happy that you like this approach. I mean, with me explaining the video, because you have a narrator in the video, but usually these videos are done for neurosurgeons and people who are really have done these approaches dozens of times, hundreds of times, and basically they do not need any further leadership in this. So I think that this interactive approach of discussing what is really already out there, and these are the context, this is the content that can be easily accessed from everywhere, can allow people to understand it better. Because one of my primary goals with this Roton is to make neurosurgery understandable for people, as I try to make it understandable for myself and for the colleagues here. So I think that's why I'm using also the videos which are pre-made, which are on YouTube, and which are from representative companies, channels, and associations such as the WANS, American Association of Urological Surgeons. It's all copyrighted material, and of course, no violation of copyrights is intended. It's really intended to appreciate the work they are doing and to appreciate the effort that they have done to make this publicly available. Because in the first place, this is how I fell in love with neurosurgery. Being able to access these videos and really to want to shape my future towards neurosurgery, and in neurosurgery was a product of these very kind efforts from professionals, including the WANS, and that's why I choose to present their videos here, because as trying to pay back a bit my appreciation for what the influence they had on myself, and that's really what I would like to do. You're muted, Dr. Bennett. I just wanted to
We
notice.
just got a note from Ike
Uh,
Cherian. He just got out of the OR, and he just took out a
Wonderful.
fibrous pit, seen the basilar and all the cavernous anatomy. So,
Oh.
you know, I don't know what he means, fibrous
Mhm.
pit. Do you know what he means by that,
Fibrous pit.
Rakesh?
Well,
Fibrous. What is that fibrous pit?
No. Fibrous? Come again?
Fibrous pit. I don't know what that
Mm,
means. Maybe
Me neither.
maybe it's
No,
pituitary. Maybe
we'll ask.
pituitary. Probably right. Fibrous pituitary
oh
tumor.
yeah. Maybe pituitary, something like that. If he didn't write the whole word, but it's. I mean, there is not such structure in pathology, at least known.
Mm,
So it's kind of something that is. Yeah, but I mean, Dr. Cherin, it's really amazing to have people in our community here which are really doing surgeries
Well,
as we talk.
he's part of the network, and he may be watching now. And if you are, right, hello, um, Diana.
Basic.
Any comments or questions for Slaven?
Yeah, I'm here.
Diane?
No questions because the information was a little bit abstract. So I was kind of just following along. But I do appreciate the presentation because it was easy to follow along and kind of look at the structures in depth and in detail as you were describing them. So thanks for the presentation, Flavin.
Thank you, Dan. I really hope that you could get some overview of this because the image that I showed in the beginning was very important. I mean, just to put you in place because that's the occipital part of the skull, and you go laterally, and what you see along the way. So it's. I think it's very easy to think in this manner. I mean, you know the anatomy basics, and then you just go. You have the scalp, you incise it. You have the skull, you open it. You have the dura, you open it. You have the cerebellum, you retract it, and you have the nerves and the tumor. Boom. That's it. I mean, it's very simple,
Yes.
and usually everybody needs to use crutches on the way and to help, and that was my intent. So I really appreciate your feedback because I know it's very hard to combine the most diverse complexities and the simplest of things, but I tried. I at least tried so, and that's why I really wanted to emphasize this comment section and discussion section because it helps me to address your questions and to help you in better understanding this. So thank you. I hope that you really could. That for now you will be acquainted with the retrosigmoid approach and I mean how this is done because it's really one of the major topics in this area. If
Well,
you know how to do this approach, it really allows you to think about many of pathologies in a neurosurgical perspective. Please, Dr.
this
Bennett.
is directed at both Diana and Slaven, who have a career in neurosurgery in mind. Is that participating in these types of video conferences is a plus, I feel, because you'll have a record of participating, and also just being in the middle of this type of educational process, it's bound to brush off the things that you were talking about, Slaven. And when you make neurosurgery your world, it's going to be your world. It's going to be your world. And I think neurosurgical residency programs will pick up on this. We'll see that you're really dedicated to it, and you'll have concrete proof of your participation.
Yes,
So,
I agree with that.
hey, any closing questions or comments for Slaven, Rakesh?
Yeah, one thing is I like Slavin's persistence, and I hope every week we have such thing. And first one, the second point is please combine a simple ANS video after your Roton presentation. And thank you so much. Thank you so much.
Yeah, we like to see more of them, Slaven. We like to see more of them. Really,
Yeah.
they're excellent.
Of course,
They're really good teachers.
But I also wanted to, yeah, thank you very much because what I also wanted to do is maybe we will do this next Sunday or the next approach we will discuss is far lateral approach, but or a transcondylar approach, which is the extension. But I would also like to organize. I just need to think this out a bit. The operative neurosurgery alone sessions. We will just go through a few videos and discuss them. You know, this will be brief sessions, which really, I hope, enable us to appreciate the neurosurgery in movement. So how it's done, and not to really waste. How can I say, to complex our minds with all the anatomy and stuff. This will really, I think, allow us to just admire and in the same way learn how clinically neurosurgery is done. I mean, in the specific case. So this is something I want to do, and these videos are usually commonplace in my presentation. So Rakesh, of course, this is the rule. Thank you so much.
Okay, we'll talk about the direction after the show. We'll just wrap this up. Thanks everybody for coming.
Thank you very
Thanks
much.
Diana. Thanks
you.
Pradeep. Thanks Rakesh. And of course, thank you Slaven. And we hope to see Slaven next week. Same time, same channel. Thanks all for coming.
Thank you very much.